presentation on your experiences with silver diamine fluoride in the United States.
Thank you, Ramon. So where I'd like to start is a descriptive analysis of the problem. Next slide, please. In the US, how we've introduced silver diamine fluoride, and then our New York City and New Hampshire school-based caries prevention program. Next slide, please. So conceptually, the US has a significant caries problem as a developed country. On the x-axis, and this slide presents what the problem is. The x-axis is time from 2000 to 2014, and the y-axis is percentage of children with caries. The bottom blue line shows what's happened over the last 15 or so years. That percentage of children with caries has gone from about 30% to 20%. And the upper line, blue line with the open boxes, the percentage of kids with caries experience has gone from about 50% to 52%. That's caries experience is untreated caries plus treated caries. The red line are the, in this country, the Hispanic Latino community with caries. So it has consistently been higher than the national averages. And what you see over the last 15 years is that there's been increased inequity. Now that's in spite of the fact that the US has gone from spending about $2 billion a year in 2000 for children's caries and to $15 billion per year in 2014. So we've gone up sevenfold, but we haven't decreased that much the number of the caries experience. And in fact, we've increased inequities. That's in spite of the fact that we have 10% more dentists and 20% more hygienists. So that's what the system is currently doing without SDF by implementing widely drilling and filling. Next slide, please. So here's another look at that. If we start at the structural determinants of health, at the top we have social determinants. At the bottom, we have person-based care. That's what people do at home. We have practice-based instruments. That's our drilling and filling. And that's what we've spent our last 100 years, but I've showed the last 15 years. Next slide, please. So what I want to focus on is program instruments, place-based caries prevention. I'm not going to talk about policy instruments such as sugar taxation and water fluoridation. I'm only going to focus on place-based caries prevention. In our context, it's school-based cavity prevention in elementary schools. Next slide, please. So what we did starting in 2003 is brought cavity prevention to kids rather than kids to cavity prevention. We parachuted into schools and we provided toothbrushes and toothpaste, fluoride varnish, glass ionomer, classic sealants of all pits and fissures, and what is called here therapeutic sealants. They're also called ART in most of the rest of the world, or the American Academy of Pediatric Dentistry calls them interim therapeutic restorations. What we attempted to do in our comprehensive prevention program is pick the most effective cavity prevention intervention for each category. So the data when we started from systematic reviews of randomized trials indicated that toothpaste, fluoridated toothpaste, reduces cavities by 25%, fluoride varnish by 40%, and glass ionomer sealants and ITRs by 80%. Our care is delivered by a hygienist working with a dental assistant. Care takes 15 to 30 minutes, and in this country, it costs about $70 all in. So $70 is for all of the people and all of the material and time. Next slide, please. This is a different look at the same protocol, just itemized it by primary and secondary prevention. So toothpaste and fluoride varnish reduce caries, again, by 25 and 40% on smooth surface. Sealants reduce caries on pits and fissures by 80%, and ITRs or ART reduce caries by about 80% on carious lesions. Next slide, please. And this is a high-level view of what we found after 6 years. In our population, 60% of kids had untreated caries, and over that time frame, we reduced that down to about 20% using just school-based prevention delivered by hygienists. Next slide, please. So in 2015, our Food and Drug Administration approved the use of silver diamine fluoride, so we began to switch gears, moving to what were called carried away version 2.0. Again, use parachuting into schools, now in New York City and New Hampshire, using fluoride toothpaste and toothbrushes, not fluoride toothbrushes, just fluoride toothpaste, fluoride varnish, and now silver diamine fluoride rather than glass ionomer. Care is delivered here by either a hygienist or a nurse working with a dental assistant. Time takes us about 10 minutes per visit, and it costs us about $25 per visit all in. So about 1/3 the time and about 1/3 the cost. Next slide, please. This is again, another view of the same thing of carried away version 1 versus carried away version 2. Again, looking at primary and secondary prevention, so you can see the comparison of the smooth surface, so that hasn't changed. Pits and fissures hasn't changed. We're simply swapping out interim therapeutic restorations and sealants using glass ionomer with silver diamine fluoride, and our hypothesis, as you can see from the table, is that they should be equally effective. Next slide, please. And this is our preliminary results. We had a 1-year pilot in New York City. We're currently in the 2nd year of a 5-year cluster randomized controlled trial with 15,000 children in New York City and about 10,000 children in New Hampshire. So about 25,000 children altogether. New York City is largely an urban, water fluoridated, Hispanic, Latino, Black community, low income. New Hampshire is largely a rural, non-fluoridated, white community. So we have truly opposite ends, if you will, of the social spectrum in terms of rural and urban, and very different socio-economic, ethnic populations. And we expect that that red line over the next 5 years will begin to parallel our experience in Boston. This is the largest clinical trial of caries prevention among U.S. school children in U.S. history. Next slide, please. Our preliminary modeling, and this is published in the American Journal of Public Health, our preliminary modeling suggests that universal caries prevention could eliminate 80% of children's caries and cost less than 1/5 of what Medicaid currently spends for children's oral health. That's that $15 billion that I shared with you. Medicaid is our national insurance program for children's health, not just oral health, but children's health. Next slide, please. Our modeling also suggests that it isn't relative just for children. It's implementable across the health spectrum, the age spectrum, from pregnant women to children to adolescents to adults to the elderly. Next slide, please. Thank you very much.
Rick, thank you very much for that presentation. There will be a time for question and answers later, but can I just, at this stage, ask for some clarification?
Of
the
course.
difference between SDF alone as opposed to SDF and glass ionomer, what were your findings?
So that was on the slide with the red and blue line. We only have 1 year of outcome data for the silver diamine fluoride versus the 5-year outcome for the glass ionomer, and it looks like they're quite similar. At least they're trending in that direction, but it's too soon to tell.
The other question, and the last one at this stage, is that in many parts of the world, a toothbrushing scheme in schools is relatively commonplace. Would you advocate doing a toothbrushing with possibly fluoride varnish and SDF? Is there a synergistic effect of adding all three?
So that's a great question. There's the issue of residuality. That is, if you look at each one individually, toothpaste reduces cavities by, say, 25%. That leaves 75% untreated. If you use fluoride varnish alone, it's, say, 40-45%. That still leaves 55% untreated. So I think you need, and the data suggests you need all of it to work. Whether you need both silver diamine fluoride and glass ionomer is an open question. Either one has 80%, but whether they're additive or not we don't know. The suggestion is to make it simple. If fluoride varnish eliminates 50% and we just do fluoride varnish, how do we get rid of the other 50%? Well, let's say we use silver diamine fluoride. It's going to reduce 80% of that 50%, so you're still going to have untreated caries. So there's nothing that's going to be 100%.